सो हेलो गाइस, वेलकम बैक टू माय चैनल मैड पाथ विद पीयूष। और आज हम शुरू करने वाले हैं सीएनएस इन्फेक्शंस की वायरोलॉजी के अंदर टॉपिक, जो कि बहुत ही इंपॉर्टेंट है एज फार एज माइक्रोबायोलॉजी, एज फार एज अगर हम देखा जाए तो पीएसएम में भी। ठीक है, तो दैट इज पोलियो वायरस। ठीक है, तो चलिए शुरू करते हैं। तो वायरल माइलाइटिस जो है, ठीक है, इट इज़ वन ऑफ द मोस्ट कॉमन इन्फेक्शियस कॉजेज ऑफ माइलाइटिस। अगर हम कंपेयर करें बैक्टीरियल माइलाइटिस और वायरल माइलाइटिस में से, तो वायरल कॉजेज आर मच मोर कॉमन। ठीक है, व्हेन इट कम्स टू माइलाइटिस। ठीक है, और अगर पोलियो की बात करी जाए तो इट इज़ अ हाईली इन्फेक्शियस चाइल्डहुड डिजीज। ओके, very highly infectious it is. It causes acute flaccid paralysis due to nervous system involvement. So what is the important point to learn here is that it causes acute flaccid paralysis, or in short form you can remember it as AFP, acute flaccid paralysis. Okay, it is one of the characteristic features of poliomyelitis. Okay, now coming to morphology of polioviruses. So they are a type of enterovirus. Okay, they are a type of enteroviruses. Okay, and they belong to family Picornaviridae. Okay, so this is also important, which family they belong to. That can be your one of the MCQ questions. They belong to Picornaviridae family. They are spherical in shape with icosahedral symmetry. See, there are very less, RNA viruses which are icosahedral in symmetry. Okay, you will find some with helical symmetry, some with some other symmetry, but it is one of the virus which shows symmetry like DNA viruses, known as icosahedral symmetry. Okay, it's small, simple, and non-enveloped. This is one of the important points, that it is non-enveloped. It just has a capsid. Okay, and that capsid has subunits upon it. Okay, so let me give you a diagrammatic representation. Okay, so consider that this is a capsid. Okay, and inside there is icosahedral genome. Okay, this is looking like helical, but consider it as icosahedral. Okay, so icosahedral genome, and this is the nucleocapsid. On this capsid there are subunits. Okay, and these subunits contain viral proteins. Like consider this as VP1, VP2, this as VP3, and this as VP4. Okay, so they contain viral proteins. So this is important, that each subunit contains 4 viral proteins: VP1, VP2, VP3, and VP4. They possess the genome which is positive sense. Positive sense means it can itself act as mRNA. It is linear. Okay, as well as it is a single stranded RNA. Okay, these are the important points regarding morphology. Write this in your short note or long note, whichever comes. Okay, now coming to antigenic types of polioviruses, there is wild poliovirus which has 3 strains. Okay, it has 3 strains: wild poliovirus 1, wild poliovirus 2, wild poliovirus 3. Of this, 2 and 3 are globally eradicated. They are globally eradicated in 1999 and 2019 respectively. Okay, and there is a type specific antibody response. So if there is an antibody production against wild poliovirus 2, it will not act against antigenic structure of wild poliovirus 1. Okay, so they are type specific antibody response. Okay, now coming to pathogenesis, it's important and kind of confusing as well. Okay, so in pathogenesis the transmission is by fecal-oral route. Because why by fecal-oral route? Because it's one of an enterovirus. Enterovirus है ना? So that is why fecal-oral route more than respiratory droplets. It can be via respiratory droplets as well, but it's more via fecal-oral route. It multiplies locally in the intestinal epithelial cells, tonsils, as well as Peyer's patches. Here majorly it replicates in the epithelial cells as well as the lymphoid tissue. Which receptor does it binds to in the host cell surface is the CD155 receptor. Okay, it binds to the CD155 receptor on the host cell surface. So now next, coming to the spread to the CNS or spinal cord, it transmits via fecal-oral route or respiratory droplet. Now how will it spread to CNS or spinal cord? It will be via hematogenous spread, means via vessels, which is most common. So most commonly it spreads via hematogenous route. Okay, or via neural spread. It can directly spread along olfactory nerve or any nerve. So that's how it can spread to CNS or spinal cord. What is the site of action is the motor nerve ending. See, it has to cause acute flaccid paralysis. So it will go and act on the motor nerve endings, the final endings of the motor nerve. Okay, that means it will be affecting anterior horn cells of the spinal cord. Okay, so now coming to neuron degeneration, it will also cause neuron degeneration, and the earliest change that we will see in the neurons will be the degeneration of Nissal's bodies. Okay, the degeneration of Nissal's bodies. Now, coming to clinical features. Firstly, there is incubation period that is of 7 to 14 days. You can just remember 1 to 2 weeks if that's easy for you. Okay. Now, there are four types of clinical presentations that you will see. Okay. First is asymptomatic. So, majority of the cases, that is about 90 to 95% of cases, are asymptomatic. Secondly, is the abortive infection. That means infection will occur and it will resolve in some time. That will be characterized by fever, malaise, myalgia, or anorexia. Okay. Thirdly, will be non-paralytic poliomyelitis. Means there will be infection, but it will be non-paralytic. Okay. So there will be aseptic meningitis. Okay, that is characterized by aseptic meningitis. Fourth will be paralytic poliomyelitis. So you have to remember these four in order: asymptomatic, abortive infection, non-paralytic poliomyelitis, and paralytic poliomyelitis. Paralytic poliomyelitis is the least common form that you will encounter. It's even less than 1%. Okay. What you will see in it is descending asymmetric acute flaccid paralysis. We will find acute flaccid paralysis that will be asymmetric, means right to left will not be equal every time, and it will be descending from up to down. Okay, proximal muscles are affected first and then the distal are affected. Mostly it starts with hip and then it spreads to the extremities. Okay, there is a tripod sign that you will see in case of poliomyelitis. The child will sit with flexed hip and both the arms are extended towards the back for support. Okay, so both the arms will be extended behind the back for support and there will be flexion of hip. In paralytic poliomyelitis, you will find a biphasic course. Means firstly there will be aseptic meningitis. Okay, that is like non-paralytic poliomyelitis. There will be recovery and again there will be return of fever 1 to 2 days later with paralytic features. So that is means that is showing the biphasic course. Okay. So now coming to lab diagnosis. In lab diagnosis, there are specimens that we take are throat swabs or rectal swabs or stool samples. CSF and blood is very rare. This is important point. Mostly we think when it is a cause of a CNS infection, we'll go for CSF examination. But in this case, CSF or blood examination is very rare. Up to 3 weeks, you'll find a specimen in a throat swab, and up to 12 weeks, you'll find a specimen in a rectal swab or a stool sample. Okay, you can also do sewage testing. Transport can be done, and the virus should be kept frozen at all times while transporting. In cell lines for cultivation, there should be use of primary monkey kidney cell lines, in which you will see the cytopathic effects in 3 to 6 days. For serology, you can do antibody detection by neutralization test. In molecular methods, you can go for real-time RT-PCR. Okay. Now coming to a very important topic, that is vaccines. For this will be helpful in your microbiology as well as your PSM. So please listen to it carefully. There are two types of vaccines for polio. There is injectable polio vaccine, that is IPV, and there is oral polio vaccine, that is OPV. Okay, OPV is also referred to as Sabine vaccine, and IPV is also referred to as Salk vaccine. Okay, so firstly, which type of vaccines are there? OPV is a live attenuated vaccine. Okay, very important point. Well, IPV is an inactivated vaccine. Okay, IPV contains all the three serotypes 1, 2, and 3, and it is given in two doses: a full dose IPV or a fractional dose IPV. Full dose means पूरी dose दे रहे हो, fractional means कुछ dose दे रहे हो. Okay, so full dose IPV or fractional dose IPV. OPV can be given in three forms: trivalent OPV, in which serotype 1, 2, and 3 are included; bivalent OPV, in which serotype 1 and 3 is included, because serotype 2 was the earliest to be eradicated in 1999; and monovalent OPV, which will contain only one serotype. Okay, how are the doses given in national immunization schedule? For IPV, there are two fractional doses which are given intradermally at upper arm, 0.1 ml per dose, because the fractional IPV is given intradermally. That is why less dose is given, 0.1 ml in upper arm, given at 6th and 14th weeks of age. While there are 5 doses that are given of OPV, okay, that is of bivalent OPV 1 and 3. 2 drops per dose are given. 0 dose at birth, first, second, and third dose at 6th, 10th, and 14th week, and booster is given at 16 to 24 months. Okay, taking the point of safety, I've already told that OPV is a live attenuated vaccine. That means it is safe, but it will not be safe in in patients that are immunocompromised, having pregnancy or old age. While safety would be relatively much more safer in case of IPV. Okay, considering the efficacy, both are very much efficacious. In considering economy, OPV is much less cheaper than IPV. Okay, so it's much more economical. Duration, it's much more lasting. OPV is much more lasting. In epidemics, OPV can be used. Why? We will discuss. Okay, herd immunity is not provided by IPV. Why? Because for herd immunity, the virus should be shed in fecal-oral spread. Okay, and as OPV is a live attenuated vaccine, it is shed in fecal-oral route. Okay, because of this fecal-oral spread, there is herd immunity. Local immunity is also stimulated via OPV only. Okay, OPV should be stored at minus 20 degrees Celsius. Okay, it should be stabilized in MgCl2 and pH should be less than 7, while IPV is relatively stable. Okay, so it does not require stringent conditions. Okay, now getting the chance for VAPP and VDPV. What is VAPP and VDPV? We will discuss just after some time. I will just tell you the full form. VAPP is vaccine associated paralytic polio and VDPV is vaccine derived polio virus. Okay, so IPV has zero chances of producing VAPP or VDPV, while there is relatively more chance of producing it in oral polio vaccine. We will discuss it further. Now, coming to advantages and disadvantages of both of these vaccines, IPV is much safer than OPV. Okay, it does not cause VAPP or VDPV, and it is more stable. So these are advantages. Disadvantages: it does not provide herd immunity. It does not provide any community protection. It does not induces local immunity, and it is expensive than OPV. While opposite to this, in OPV, there is herd immunity because there is spread in community by fecal-oral route. OPV is the vaccine of choice during epidemics. Okay, IPV cannot be used in epidemics, while OPV can be used in epidemics. OPV induces mucosal IgA production, that is why it stimulates local immunity. It is cheaper than IPV and it is easier to administer as it is given by oral route. While disadvantages, OPV is less safer due to being a live attenuated vaccine. It requires many factors for its stability, like storage at minus 20 degrees Celsius, stabilization in MgCl2, and maintaining pH of less than 7. And especially OPV can cause vaccine-associated paralytic polio and vaccine-derived polioviruses. Now, let's discuss about these. What are these? So, vaccine-associated polioviruses, paralytic poliomyelitis means when all the cases of paralytic polio that occurs following OPV administration, means you are giving OPV and because of that administration of OPV or vaccine, there is production of paralytic polio. This happens because it is a live attenuated vaccine. It has live viruses, okay, which are attenuated but still are live. So it can occur among OPV recipients as well as to their close contacts. But VAPP strains are not capable of circulating in community and do not cause secondary cases of outbreaks. This is important. They do not circulate, but these are caused due to administration of OPV. Okay, most common serotype that causes VAPP is Sabine type 3. That means OPV monovalent 3. Okay. Now, vaccine-derived polioviruses. That means such are the vaccines which have live attenuated vaccine strains in oral polio vaccine which may undergo genetic changes, okay, such as to produce poliovirus. Okay, so these were meant to protect the individual, but they got genetically mutated and they are now eventually causing polio virus. Okay, so they are capable of producing poliomyelitis. They are clinically indistinguishable from wild polio viruses. Okay, so that is the problem. Okay, because they are acting now as polio virus only. They are genetically mutated. Okay, these are of three types. Okay, these are important. Okay, circulating VDPVs, immunodeficiency associated VDPVs, and ambiguous VDPVs. Okay, and they can spread from person to person. Okay, by fecal-oral transmission, so they can cause outbreaks. So this is one of the differentiating features between both of them. The occurrence of circulating VDPV cases is more than that of VAPP, as it can spread in community, while VAPP does not spread in community. Coming to epidemiology, man is the only known reservoir of poliomyelitis. There is no other reservoir or animal reservoir. And in age comparison, it is, we have already discussed, it's an acute infectious disease of children, so it affects younger children and infants more than adults. And there are some endemic countries right now as well, although it's globally eradicated. uh, 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 Polio virus 2 and 3 are globally eradicated, but still there are some countries which are endemic to polioviruses. That is PAN. You can remember by PAN: Pakistan, Afghanistan, and Nigeria. So, guys, that was it for polioviruses. So, most important things in this will be, you know, knowing about the wild polioviruses. Its structure having four viral proteins, okay, out of which VP1. Because of VP1, there is the differentiation between wild polioviruses. Okay, some things about the pathogenesis, the four stages of clinical features. Okay, and then about the vaccine. Okay, so these would be the important topics. So thank you guys for watching this video. If you liked the video, please press on the like button, subscribe to my channel, and if you want to reach out to me, you can reach out to me on my Instagram. And if you want any video or have any suggestions, please give them in the comment sections. Until next time, bye bye.